discuss also utilization of percutaneous VADs in valvular lesions.
Great case. Thank you.
Dr. Wald?
Thank you. So thank you to Marwan and the panel and moderators. I have the privilege of talking about this very small topic of utility of temporary MCS devices in valvular shock. I'm the medical director of the shock team at Penn. And so to highlight the C3TN work that was done, that was already shown, that we know that patients who are taken care of in centers which have a cardiogenic shock team in the dark blue lines on the left versus those who do not have a cardiogenic shock team on the right, that PA catheters are used more frequently, that overall MCS, temporary MCS, is used less frequently, but when it is used, it's usually more advanced temporary MCS as opposed to balloon pumps. And this leads to a decrease in mortality. And really what was cool about this, what this group showed, is that not only did they get their PA catheters, they got them sooner. There was less inotrope use, inopressor use, less likely to need ventilator support, and less likely to need renal replacement therapy, leading to shorter ICU days and overall improvement in mortality, as was mentioned. So let's quickly talk about valves, shock, and temporary MCS. So most of these are cases that came to our shock team that I'll highlight. I'm not going to go through a lot of data slides, but really more case studies. So the first case is a patient with ischemic MR. So it can be primary, where there's an infarct that alters the geometry of the LV, secondary, or primary, where there's a disruption of this mitral subvalvular apparatus leading to severe MR. The clinical scenario is that it is an MI, including the PDA, and the posterior medial PAP muscle has only one blood supply, which is why it's particularly vulnerable. So the patient's stable, but then all of a sudden, usually at 2 to 7 days, decompensates. You need to have a high clinical suspicion. Physical exam, you might see a new holosystolic murmur. Your PA catheter waveform will change. You see on the right that you have a normal wedge tracing all the way to the right, but on the bottom in the middle that you now have a large V wave. So for ischemic acute MR, what would be your best temporary support device that you would use to stabilize this patient who's in shock to get them to the operating room? An Impella CP? Not enough support likely, because when we look at the Impella CP, and this is data showing that in the middle yellow block with the 4.1 above it, that the Impella CP has a higher risk of hemolysis, red cell damage, compared to our larger pumps. You can see here that the motor's smaller on the bottom left graph, so you need to run at about 43,000 RPMs to achieve 3.5 liters of flow, versus with a 5.5, you can get up to 6.2, 6.7 liters of flow at RPMs of 33,000. As we saw with our flow volume loops, that ECMO leads to a high afterload state, so that's not a great tool to reach for with acute severe MR. So we would choose, in this instance, an Impella 5.5 that can unload and fully support the patient and improve their end organs and then get them to the operating room. Critical AS, as we heard from our last speaker, is a problem. Oops, let me go back one. So this is the clinical scenario. This was a call we got 2 weeks ago. A 72-year-old male, status post CABG with ischemic cardiomyopathy, presented in cardiogenic shock with an aortic valve area of 0.5. Systolic blood pressure is 60. He's in the cath lab at an outside hospital. Cardiac index is 1.1. So what do? They pulled the swan. But they did a balloon valvuloplasty to allow the gradient to decrease, to pass an Impella CP through that now balloon valvuloplastied aortic valve, but was running it at blunder speed with at P9, but achieved 3.9 liters of flow. The outside hospital says he's awake, he's chatting, he's on 6 liters of O2 with Levophed at 12 mics. They of course made the diagnosis by echo or by hemodynamics. And the choices, so we have a big hub-spoke model at Penn. With our outside hospitals, we are gearing up to do mobile VA ECMO, but in this instance, we weren't up and running quite yet. We also, with our spoke hospitals, generate a hospital checklist for them so that they know what catheters we like, what size we like, where they need to be placed. This particular outside hospital was not comfortable placing the patient on peripheral VA ECMO, so we decided to do the scoop and run tact with Penstar. So the goal was to grab him while he was still viable, put him on peripheral VA ECMO with a PA catheter at the bedside, recover end organ function, then do urgent TAVR. But in truth, the patient arrived really not viable. And Dave, I think we need an SCAI stage F, because he was beyond E. He was on epi at 20, getting boluses, levo at 75, a bicarb drip and a MAP in the 30s. So he was unfortunately not salvageable. What about severe AI? So this is another shot call that we got, which is actually my nurse's brother, 43 years old with relapsing drug abuse, who was found unconscious in his home by his girlfriend, was hypotensive with no urine output, spilling lactate on Levofed at 12 and rising with a new EF of 20% and incidentally COVID positive. He has a large vegetation on his aortic valve leading to severe AI, gram-positives in the blood, and we see the diagnosis is severe acute AI. So what do? A balloon pump? No, that leads to increased afterload. That is one of the major contraindications to a balloon pump. We talked about our Impella devices, but in the setting of severe AI, you could potentially just recirculate the blood and just keep churning it through the ventricle, out the outflow, and then back in through the aortic valve. So our tact for this particular case, and ECMO, you could do that, but again, a high afterload state, so not great for acute AI, maybe ECPella or ECMO with a atrial septostomy. But we opted for going straight to the operating room for AVR. The patient did have post-cardiotomy cardiogenic shock, so was recovered on peripheral VA ECMO with the PA catheter. He was pulsatile, he didn't need a vent, and he is recovered, he's now up on the floor. And then my last case is another shock call of a patient with an ischemic cardiomyopathy, status post-bio AVR and MVR in the past, on chronic home milrinone being evaluated for durable LVAD, but re-presented to OSH in acute compensated heart failure cardiogenic shock with the hemodynamics shown there at the right. This patient was rescued. You can see it's a high SVR state with a low cardiac index, rescued with milrinone 0.375 and a balloon pump was placed. As we were working the patient up for durable VAD, we noticed that the patient had severe bioprosthetic mitral stenosis. So our options were threefold: mitral balloon valvuloplasty at the time of OR for the VAD of this bioprosthetic valve. Our structural team did not think that was a great idea. Surgical MVR at the time of VAD implant, older gentleman, longer cross-clamp time, or transcatheter mitral valve immediately prior to LVAD implantation. I'm almost done, I promise. Don't take away my slides. So in the center here is our hybrid OR with the center tables being set up for the thoracotomy, the back table for the durable VAD, and then the left table for the transcatheter structural team. And you can see here that Marisa Savasco, our surgeon, did a lateral thoracotomy, exposed the apex, put in the apical sewing ring of the LVAD. The structural heart team wanders in, slams the transcatheter mitral valve in 10 minutes, and then the VAD goes in, and the patient had a great result and is now discharged. So in conclusion, we are seeing more cardiogenic shock not due to acute MI, and from this data that you can see here from the Impella group, the Impella 5.5 group, that PA catheters are being used more, and acute MI accounts for only about 30%, and in this series of 200 patients, remarkable outcomes with cardiogenic shock at 74%. So in conclusion, our outcomes of cardiogenic shock are improving. We're seeing a lot more different types of cardiogenic shock, including non-acute MI. Early recognition is the key. Shock teams, I think, work. Early PA catheter use to allow tailored therapy. Early and advanced temporary MCS when it's warranted. And we are getting better and better devices out there to support our patients. So thank you.
Yeah, you have 4 heart valves, you need at least 2 of them. And I think the AI case was particularly instructive. There's no other, in the absence of a competent aortic valve, there's nothing else you can do.
Yeah.
All the other strategies will fail. They'll just put blood back into the LV.
Yeah.
So the only thing you could do is what you did, and that's replace the aortic valve.
Yeah, go straight to the OR.
But your presentation highlights what we discussed in the last few days. Any of the percutaneous circulatory support devices will not save anybody unless you have an exit strategy and do a great job like you did in all those cases. That is what will decide whether the patient survives or not. The MCS just gives you a little more breathing time to arrange all those things to do that. And like Dr. Caraballo says, acute AI, if there is a true medical emergency, it's an acute AI because the only treatment is surgery. There's nothing else to do.
I think the biggest job of our shock program is to educate the community as well as to educate our ER and our intensivists. So our inclusion-exclusion criteria are up in all the ORs and all the EP labs, the cath labs, the ER, and we just recurrently socialize it.
And I would just, as I'll point out when I speak, that I still think there's no replacement for physical examination of valvular heart disease. But in these acute, terrible cases, there's not enough blood flow to make noise.
Yeah.
And you could easily miss them on physical exam and say, I don't hear a murmur, because there isn't one.
I think that beautifully illustrates why this is best done with shock centers and shock teams, because you have to have the ability to do the full spectrum of treatment. And you couldn't have shown a better example of why you need that.
Thank you.
I don't know
It's
if
truly
anyone,
a team effort.
I don't know if anyone in the panel has experience with the Jena valve, but I just wonder if, in the case of AI, that's what that valve is designed to treat. If that could be, when it's available here in the U.S., if that could be an option in this emergent setting. I don't know, Sandeep, if you have any experience with it.
No, I don't.
I do.
The only comment I would have is this was clearly endocarditis. And so I would.
Usually most acute AIs are endocarditis.
Yeah.
You can't do anything.
So I probably would, I think you have to remove the vegetation and devitalized tissue. As a surgeon who's made the mistake in my youth of not getting rid of all the devitalized tissue and infection, I've had the opportunity to come back and do it again and do it the right way later. And so I think leaving anything behind, which you would with the TAVR, is not recommended.
I think it's an important point for me also to add as well is the hub and spoke model you build there. It's important because it's not every hospital have that kind of expertise to take a decision to decide about such kind of complex case regarding decision making and also going to the OR and operate such kind of complex case.
Yeah, great.
Perfect.
Okay, thank you.
Okay.